gentlemen. Today we'll be presenting Chapter 11, Skull, Facial Bones, Anatomy, and Topography. This is our next unit in radiographic procedures. I'm going to spend about 3 to 4 weeks on Chapter 11, break it down into its component parts, the anatomy and topography of the entire skull and the facial bones. And those are two separate areas of the cranium. The skull proper is the bony housing that envelops the brain. The facial bones are typically those bones that are anterior that make up the bones of the face. And so there's two separate sections to the cranium. Maybe the first thing you learn. Maybe the second thing you learn is that pirates had pretty accurate anatomical representative flags and decals and, whatever you want to call it, icons. So the pirate flag seen here, and I think this is from Historical Archive, not only did they know anatomically correct what a skull looked like, nice zygomatic arches there, nice nasal cavity, and then also the temporal region, the divot in the lateral aspect of the skull. On the lateral edge of the orbit, there's a little divot on each side right behind the orbit, and that's the temple. And the pirates knew about that. So whoever was the artist that created the pirate flag, or at least this pirate flag, he had seen a real human skull in his lifetime to make such an accurate depiction here. So I just think that that's a cool little detail to this pirate flag. So, and why isn't the slide advancing? There we go. Now, pirates were not the only ones to use images of skulls in artwork, and I've actually, for a little bit of culture dribbled into your X-ray curriculum, the picture here on the far left, which is a young woman looking into a vanity mirror with a kind of a lace tablecloth hanging off the vanity, representing the mandible. This is titled All is Vanity. It was painted by Charles Allen Gilbert. The middle one is Salvador Dali, and it's not so much a painting as much as it is a photo of Mr. Dali. And he had some, about 7 women nude, arranged themselves in such a fashion that they represented a skull. This is one of his pieces, one of his works of art, but it was really it was more of a live display than it was a painting on canvas or anything like that. But it was photographically represented, and it is the form of a skull as well. And then room with a view, as it's sometimes called, or room skull, is the alternate name for the picture on the far right. And that was painted by Ali Gulick. And I'm sorry I didn't dig deeper and figure out when these were painted, but clearly skull imagery in. I like how Miss Gulick with the 2 cats accurately represents the bony nasal septum with the space between the 2 cats. That's a very nice touch. So our objectives for this exam, remember, or not this exam, this lecture. Our objectives for this lecture, remember, we're breaking this apart into components so that we can extend the amount of time we take with the skull. And the reason for that is, with most of the other topics in procedures, we rely on reinforcement in clinical education. That is to say, you're going to see these exams, you're going to see like an ankle exam. I can teach you an ankle exam in the course of a single afternoon, without reinforcement, without coming back to it multiple times, and just explain it to you once or twice, and that's enough effort from me, because I know I'm going to send you to clinical education where you're going to get reinforcement of those concepts, the positions, the anatomy, so on and so forth, by actually performing those exams on live patients. So the remediation and the multiple touches is built into the clinical education with some of the more common exams that we've already covered. Excuse me. The skull and the facial bones, that's not the case anymore in modern radiography. We've got this wonderful piece of equipment called a CT scanner, and it has stolen a lot of the plain radiography studies that we used to do, that the positions of this chapter that you're going to learn, because it's still mandatory for you to learn them. But are you going to see these exams with any regular frequency going forward in your career? No, you're not. So this is another one of those times where we're addressing subject matter because it's required by the recommended curriculum, not necessarily because it's going to be practical with any frequency when you go into your job. So, but you have to know it to pass the exam, so I'm teaching it to you. And I'm taking my time doing so, breaking it apart in about 4 lectures over the course of the next 3 or 4 weeks, such that we can create more touches with the material in the classroom, anticipating that it won't be reinforced in the clinical setting because the frequency of these exams is poor anymore because of the CT scanner. So what are we going to do for this lecture? We're going to talk about the anatomy, the topography, the morphology, which I didn't mention here, but morphology. So what are those things? Well, the anatomy is just the names of the bones and the names of the parts of the bones, and the names of the joints and the names of the parts of the joints. We have special joints called sutures. And then we also have palpable landmarks. We have about 6 or 7 of those. Don't quote me. But we're going to cover the palpable landmarks. And then we also have topography, which is drawing lines between various points of anatomy. So we'll have positioning landmarks, and then we're going to connect those positioning landmarks with imaginary straight lines, and then we're going to use those topographic lines to describe the positioning of the skull. Okay, so one of the lines will be the orbital meatal line, which is a line that connects the outer canthus, or the outer corner of the eye, to the EAM. All right, so just imagine a line drawn from the outer corner of your eye back around the side of your head to the hole in your ear. That's the orbital meatal line, and it's used as a reference line for 3 or 4 of the skull positions. So, and a couple of the facial bones positions too. So that's just one of the lines. We're going to learn about 4 of the 4 or 5 lines of topography with their start points and end points. 4 of those lines, one of the endpoints is the EAM. So they all kind of fan out from the EAM and connect to various anatomy on the face. Review anatomy pertinent to the facial bones and skull exams. That's going to more tie into the next lecture. So I will be pointing out various landmarks, and I will try to mention, oh, this is going to show up on this projection, this is going to show up on that projection, as I'm pointing out the anatomy to you in this lecture, but you're not going to know those projections until next lecture. So to tie the positioning in the procedures lecture to the anatomy lecture, that's how I'm going to do it. I'm going to, as I'm referencing different points of anatomy on different bones within the skull or the face, I'm going to say this one reveals itself. It shows up really well on a Caldwell projection. You're not going to know what a Caldwell projection is until next lecture, but it gives you a tie back to this previous lecture, um, and an effective way to kind of get to the practical application of these concepts. All right, so first practical application, because whenever you are x-raying the skull, typically it's a trauma type scenario. Again, 90% of skull and facial bone x-ray has been swallowed up by CT, because CT is just faster and better and reveals more detail. Okay, a little bit more radiation, but reveals more detail. Now, in the case of trauma, a lot of times you're going to have to spot the mid-sagittal plane of the skull, and you might think that the bridge of the nose, the high ground of the nose coming down from the forehead in between the eyes, is a good reference point to cite the mid-sagittal plane, but as the picture demonstrates, that's not always the case. So might be better to use a different reference point. Clearly this man, now this is an obvious case, clearly this man's nose is bent and broken. And again, he was hit by a man with using a right hand, which is most common. The nose is just like the zygomatic arch on the left side of the face is the more common one to blow out, because most people are right-handed. The nose, when it breaks, usually deviates toward the patient's right and away from the patient's left, because again, it's usually a fist that deviates and breaks a nose, and therefore the fist typically comes from the puncher's right, and so the nose deviates to the patient's right. Okay. So just a remembrance that the nose may not always be at the mid-sagittal plane before we begin. All right. Skull anatomy. First thing, diploe. You might have heard this term in Mr. Shepard's anatomy and physiology class. Most of the bones of the calvarium, that is the dome of the skull, are classified as flat bones, even though they're curved. There are flat bones, and flat bones feature diploe, which is a sandwich of spongy bone. See the trabeculi? It looks like a Thomas's English muffin, but it's not. It's a sawed up cadaver. There's compact bone on the inner layer and the outer layer, and sandwiched in between is a thin layer of spongy bone, and they give it a special name just to confuse you. They can't just call it spongy bone or a thin layer of spongy bone. They have to call it diploe, just to make a new vocabulary term, just so they can ask you another question on the registry. So it's a thin layer of spongy bone in between two layers of compact bone to form the structure of flat bone. All right, anatomy review. Now, I would recommend you'll find this picture in your Merrill's Atlas, Chapter 11, both an anterior view and a lateral view. So as we go through the anatomy of the skull, I would recommend you turn to that portion of your chapter and follow along with this PowerPoint. So this is the anterior view of the skull. We can see the frontal bone, part of the sphenoid bone in the light blue, the temporal bone on either side, and then they have, the parts of some of the frontal bone. I'll get into those in a minute. Okay. So first and foremost, the cranium entirely is divided into two sections. The cranial, or the entire skull, is divided into two sections. The cranium, which is the housing for the brain that is composed of 8 bones. And then the facial bones, which are the bones that make up the face. That's 14 bones make up the face. 8 bones make up the cranium. Together, 22 bones make up the entire skull. We will get to the 14 facial bones at the second part of this lecture. We're going to start with the 8 cranial bones and dive deeper, show them disarticulated and separate from the rest of the skull in various aspects, typically a lateral and an AP aspect to each of these, so you can get a good idea what they look like separated from the skull. And then the cranium is further subdivided into the calvaria, which is the dome, and the floor. Okay, so the calvaria is the frontal bone, parietal bones, and the occipital bone, and then the floor is the sphenoid bones, the temporal bones. Okay. And there might be, I'm not sure if the frontal bone is counted as part of the floor as well. We'll have to see here and say, I think it is. So the calvaria, frontal, occipital, right and left parietal. So 4 bones there. And then the floor, ethmoid, sphenoid, right temporal, left temporal. Okay, so they don't count, even though the frontal bone is clearly 1/3 of the cranial floor, they're not counting it. So they only count this part here. The ethmoid, which is this purple strip, it's the perpendicular plate of the ethmoid bone. So look at the very top of the diagram. You see the purple or the magenta, very, very tiny bone at the midline. That's the ethmoid bone. Behind it in the light blue, that's the sphenoid. And then in the tan to calf scour khaki color, on either side is the temporal bone. And then the off yellow, again not counted as the cranial floor, is the occipital bone. So the frontal bone in, like, what is that, strawberry, and then the occipital bone in the dirty yellow, those are not counted as the cranial floor, even though clearly they're making up part of the cranial floor. I didn't write the book of anatomy, I just describe it, right? So all these individual parts, yeah, we're going to get to those. Will you have to know them? Yeah, you'll have to know them. The big one, the foramen magnum occipital bone, but you should also know the jugular foramen and the foramen ovale, okay, which is on the sphenoid bone, and then the jugular foramen is between the temporal bone and the occipital bone. All right, there we go again. My point, just go back to the AP view of the skull that we see in the book versus the depiction of the skull on a pirate flag painted by a pirate artist at some unknown date and time. But I love look at the nasal cavity and the accuracy of the shape of that hollow fossa for the nasal cavity. The orbits are, look how the orbits are not perfectly circular. There are ellipses with drooping foots at the lateral, the bowing of the ellipses is laterally and inferior, just like the real shape of the orbit. And then of course the temporal regions are accurately represented by shadows. And then the cheekbones, the zygomas, are dang near perfect in shape. Look how he's got the little zygomatic prominence, the protuberance of the zygoma laterally. That's fantastic. And then the mandible that actually tucks in under the zygomatic arch. He's got that represented good too. So fantastic job. And then if those are humeruses that are crossed below that he did a good job of representing the intertubercle groove and the olecranon fossa on either end of those humeruses. So very nice job. And I assume one of those is the greater tubercle and the other one is the medial epicondyle of the humeri. So excellent job by this pirate artist to get the anatomy authentic, considering it was black cloth, a little bit of whitewash, and probably a handmade paintbrush to paint that. So nice job. All right, our cranial floor, internally divided into 3 regions: anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. So I just got done telling you that there were only the true cranial floor bones were the ethmoid, sphenoid, and left and right temporal bones. But now we've contradicted ourselves and we've included the frontal bone in the anterior cranial fossa, the frontal bone in the ethmoid bone, and then the middle is the sphenoid and the temporal bones, and then the posterior cranial fossa is the occipital bone. So now those are fossas, not necessarily the floor itself. So those are the spaces represented by the cranial floor. Okay. Sutures actually don't form until after you are born. Newborn babies don't have sutures. They have soft spots or fontanelles. Now, those are basically the growth plates, the epiphyseal plates of the flat bones of the skull, and eventually the parietal bone grows and expands until it meshes with the occipital bone, until it meshes with the temporal bone, until it meshes with the frontal bone. And all of these bones, just their squamous portion just keeps expanding outward until the fontanelles get smaller and smaller and smaller, and eventually sutures and suture junctions form sometime in childhood. I want to say definitely by the time the child is 5 years old. I want to say even as early, now don't quote me on this, but even as early as I think the skull solidifies and gets rid of the soft spots somewhere, I want to say as early as 2 years old. Definitely by 5, but I don't know that for sure. I do need to look that up for you. That might be a registry question as to when does the skull form and the fontanelles disappear. I know newborns have soft spots and fontanelles. In fact, that you can actually measure the pulse of a newborn by watching the pulses of, or the fluctuations of the anterior fontanelle. The baby's heartbeat can be recorded by watching the anterior fontanelle, and it will bounce up and down with the patient's heart, with the baby's heartbeat. So it's pretty cool, actually. Eventually these things close and form sutures between the frontal bone and the parietal bones. That's called the coronal suture because it lies on a coronal plane. And then the sagittal suture forms on the top of the head between the 2 parietal bones. Okay. Well, that's interesting. The frontal bone starts as a left and right half, but you don't have a frontal suture when you're an adult. So that's weird how the coronal suture forms, but you have a sagittal suture between parietal bones, but you don't have a sagittal suture between frontal bones. When you get old, that just fuses. It doesn't form a suture like the parietal bones do. And then the occipital bone forms a suture with both the parietal bones and the temporal bones. So you get a lambdoidal suture but you also get a squamosal suture between the temporal bones, the occipital bone, and the parietal bones. And then you might notice that there's junctions of sutures, both um, on the top of the head at the junction of the sagittal and the coronal suture, and then posteriorly at the lambdoidal suture and the sagittal suture, and then two junctions on the lateral aspect of the cranium, one anterior and then one posterior. And we'll get to the names of those junctions in just a minute. For now, recognize the sutures and where those are. All right. Morphology, which means shape. Morpho means shape or form. So the study of the shape or the form of the skull, we have figured out that there's basically three types of skull. There is the typical, and by typical we mean most common variant, is a mesocephalic skull. The mesocephalic skull is about as wide as it is tall. And that's typically the variance, is the width of the skull to the height of the skull. So when it's about as wide as it is tall, you get a mesocephalic skull, which is what the standard positions are based on, is mesocephalic morphology. In a mesocephalic skull, the petrous pyramids or the petrous ridges make an angle of 47 degrees with the posterior mid-sagittal plane. Okay. Will you have to memorize these angles? Yes, you will. Mesocephalic, 47 degrees. Okay. Now, what happens if the head is a little bit wider, but a little bit squatter? That is, not as tall, but wider side to side. Well, those would be the Irish people, and the Irish people have bradycephalic heads. Bradycephalic heads seem to be almost mason jar shaped. They are almost circular. That is, the depth from front to back is almost the width from side to side. So it's almost a perfect cylinder in the bradycephalic skull. The bradycephalic skull, because, God, I can't say that. The bradycephalic skull, because it is wider side to side, those petrous ridges are allowed to expand more laterally than they would in the mesocephalic skull. So the angle to the mid-sagittal plane actually increases to a 54-degree angle, right? Well, that changes where the petrous pyramids will be located relative to other anatomy when you're doing these positions. And what we're going to find out is the petrous pyramids are the most densest bony anatomy in the entire human skeleton, and that's for soundproofing. The petrous pyramids house the middle and inner ear and those organs, the organs of hearing. And so the petrous pyramids are made out of thick, compact bone that is very hard to penetrate on an x-ray and makes for a nasty, natural superimposing anatomy that the whole reason for our positions is to get the petrous pyramids the hell out of the way of what we're trying to see. So the petrous pyramids and this morphology is important because the standard positions that I teach you are going to be based on mesocephalic. If you encounter a bradycephalic or a dolichocephalic head, well, then the tube angles are either going to flatten or they're going to be exacerbated. You're going to either have to curb the tube angle. Let's say for like the Caldwell projection, it's 15 degrees. 15 degrees caudate. Okay, PA projection of the skull, 15 degrees caudate. That's for mesocephalic. Bradycephalic, I don't know. Do you reduce that to 10? I don't know. I've never made that adjustment because again, you don't do them that often. But the chapter seems to indicate, the author seems to indicate that the point of teaching you the different morphologies is the Petrus pyramids will lie in a different position, and the whole point of applying an angle is to move the Petrus pyramids relative to normally superimposed anatomy. So because they lie in a different orientation with the different skull shapes, tube angle will be either more effective or less effective because the standard positions are based on mesocephalics. All right, so that's why we're teaching you these. Now we can probably set up an experiment. That would be a cool thing to do, is let's set up an experiment with let's set a radiopaque body at a 47-degree angle to a mid-sagittal plane, and then let's set up another piece of anatomy that would be on the horizontal vector, but then let's shoot it at 15-degree down angle to remove superimposition, and then let's change the angle of the radiopaque object from 47 degrees to 54 degrees, and let's see, with the same 15-degree down angle, is that more effective or less effective at creating the superimposition? I'm going to gamble that it's going to be less effective, but we can set up that experiment. That would be a cool thing to do. And it would be fairly simple. We just need 2 objects and a protractor, and then a CR plate and an X-ray tube. So, and then position them so that there's a certain OID and a certain angle of the 2 objects, in particular the ones doing the superimposing. All right, dolichocephalic skull, a 40-degree angle. So this is a skull that is narrow from side to side, but more vertical in its form. So it is long front to back, but it's also taller. It's a taller orientation to the skull. So now the Petrus pyramid is oriented at just a 40-degree angle to the to the posterior mid-sagittal plane. So you can memorize these. You can memorize. You do have to memorize the names. Mesocephalic is the typical one, and the typical one is 47 degrees. Okay. +7 is about 54 degrees. It's actually 53 degrees, but about +7 degrees. That's the bradycephalic. Okay. And then -7 degrees, that's 40 degrees. That's the dolichocephalic. Okay. So the let's see, the Pacific Islanders, the Asian ancestry folks, so Japanese people, Korean people, Chinese people, more so, and more so it's Pacific Islanders like Laotian, Vietnamese, and Japanese, not so much. Chinese people have a lot of bradycephalic skulls, and so do Koreans. And so you can't say all Asians. That's, it's a little stereotypical. But yeah, Japanese people have dolichocephalic skulls by and large, and a high percentage of Vietnamese, Laotian, and Pacific Islanders, Philippine people have dolichocephalic skulls as well. So not all Asians, but some Asians have. There's a greater prominence of dolichocephalic skulls in some Asian cultures, more so than other parts of the world. So, like I said, positioning guidelines. So when I teach you positions next week, and I teach you tube angles and centering and positioning and how much do you tip the skull forward or backward, what topography line should be running horizontal, which topography line should be aligned with the central ray, which one should be perpendicular to which plane of the body should be perpendicular to the central ray, the specific position of the skull, and the specific tube angle, and that's where it's going to show up. That's where the adjustment will be easiest to be made. Would be either a slight decrease, I would say -5 degrees or +5 degrees of tube angle in the PA or AP projections is probably going to be the most common adjustment you would need, because the PA and AP projections that involve tube angle, the tube angle is employed specifically to get the Petrus pyramids out of the way of certain anatomy, and I'll be teaching you that next week, and with the image critique for those various projections, I'll show you. See, these are the Petrus pyramids, and by applying this tube angle, we have actually dropped those relative to this anatomy or that anatomy, so we can see it reveals this anatomy by virtue of getting the Petrus pyramids the hell out of the way. That's the secret to skull positioning. All right, so now let's jump into the individual bones. The frontal bone has a squamous portion. The squamous portion of all of our bones, that just means it's the flat bone portion. It's the part that spreads out on basically a flat surface. Now, that being said, there's a frontal eminence. If you actually test the shape of your forehead, if you start palpating your forehead, which is where the frontal bone is, you will notice that it's a very subtle divot in the middle where the two halves fused. That's kind of flat, and as you move away from that about an inch on each side, you have kind of like a proud spot where the bone is slightly more prominent. It's very subtle. It's like maybe 1 or 2 millimeters. So the frontal bone is shaped like two halves that have merged in the middle. So there's a subtle divot in the middle. It's not a true suture. It's a fusion from the newborn skull, not a true suture. Down at the bottom, the inferior anterior aspect of the frontal bone is where we see the anatomy that you have to memorize. So the superciliary arch and the or ridge is superciliary means above the eyebrow. So not when your eyebrows are flexed like you're surprised, just relax your eyebrows unless you've had Botox injections, and then you can't relax your eyebrows. But immediately above your eyebrows, there is a bony ridge. That's the superciliary arch or ridge. And then walk down through your eyebrows about halfway between the inside corner of your orbit and the outside corner of your orbit. You should feel a little divot. That divot is the supraorbital foramen. And that's actually a foramen that passes a nerve root, one of the nerve roots to the face, it actually controls the sensation of sinus pressure. So if you have some sinus inflammation, you can actually find that divot and press down and do this now. It'll freak you out. Press down on the divot and hold pressure on that divot for about a 10 count, and then let up. As you let up, you should feel some kind of clearing sensation in your maxillary sinuses and your frontal sinuses. It's actually pretty cool. It's a homeopathic. What do they call those? It's a pressure point type situation. It's a physiopathology pressure point that I was taught by a physical therapist to clear your sinuses or to the effect lasts for about 2 or 3 minutes. But if you're just miserable and you got some sinus pressure, you can actually trick and do what you're actually doing is you're impinging the nerve and causing it to fall asleep for a little bit, and then it's going through a reset, so it's not going to send you the pain and congestion signal feedback to your head for a couple minutes, because you've basically cut off the nerve impulse of the pain signal response or the congestion pressure response, and the whole nerve has to reset itself. You got to reset the sodium potassium pump all the way along the nerve, because you added that pressure to that point in the nerve. You kind of reset it to the factory default, so you can get some temporary relief from sinus pressure by just pushing in on that supraorbital foramen. So it's a pretty handy trick. Um, and then the nasal spine and the nasal bone suture, of course, is in the middle, right at the nose. And then there's a divot on the glabella. So there's a little, there's a proud spot, and then there's a divot. The proud spot is superior. So like in between your eyebrows, there's high ground. That's the glabella. And then right below that, there's a divot, which is right on the bony nasal suture between the frontal bones and your nose. It's like there's a divot right at the top of your nose. That divot's called the nasion. We'll talk about the nasion. So the glabella is part of the frontal bone. The nasion actually marks the junction between the frontal bones and the nasal bones, and we'll talk about the nasion later when we talk about the facial bones. The ethmoid bone is in both groups. It's part of the facial bones, but the perpendicular plate is also part of the cranial floor. You can't really see the perpendicular plate all that well on this anterior view, but I will talk about this anterior view. So the ethmoid bone is actually embedded inside your nose. The perpendicular plate, or I'm sorry, not the perpendicular plate, the cribriform plate is the part that forms the cranial floor. The cribriform plate is actually, you see the crista galli and you see the perpendicular plate. You see where they kind of meet, and then it's kind of like a crossroads or a four corners. That's the cribriform plate. That is the portion that's the tiny portion that's part of the cranial floor. The superior nasal concha and the middle nasal concha, those form the nasal passageways and the connections to the sinuses. There are the sinus system we'll cover when we cover facial bone anatomy, but all sinuses connect back to the conchas of the ethmoid bone, the middle and the superior conchas of the ethmoid bone. The conchas and the ethmoid sinuses that dwell the hollow spaces within the conchas form the nasal cavity and the passages, and the whole idea is to create lots of surface area and lots of mucosal membrane area, so that dust particles and pollen and bacterial pathogens and viral pathogens and basically anything else that you breathe in when you're trying to just breathe in air, all the suspensions and all the contaminants, if you will, are supposed to lose momentum by getting trapped in the labyrinth of passageways through the superior and middle conchas as you take breaths in through your nose. So the ethmoid bone and the maze-like passageways of mucosal membranes is by design and on purpose to basically act as a filter for the lungs, so you don't inhale a bunch of coal dust or a bunch of dog hair or pet dander or pollen or all sorts of stuff that would really mess up your lungs and would cause aspirational pneumonia in a heartbeat. Well, that's better treated inside the labyrinth of the nose and in your sinus passages rather than in your lungs. So that's the whole reason we have the air cells and labyrinth of the ethmoid bone. The crystal galley is just a bony prominence um, that sits superiorly to the cribriform plate. I'm not sure it has much of a purpose other than just being a big bulb of bone. I don't know. I know it shows up on X-ray. It's a landmark we see on the Caldwell projection. But as far as having any kind of purpose, I'm not sure what it's for structurally. All right, so this is like a side view, and then we cut off one of the concha labyrinths so we can see the perpendicular plate at the midline. So the one closest to us was removed. Okay, the ethmoid bone junctions with the vomer, the sphenoid, the cartilage of the nasal septum, the nasal bones and the frontal bones anteriorly, and then the cribriform plate junctions with the frontal bone to form the anterior cranial floor. Okay, so it's kind of a weird shaped bone, but it sits right in the middle of your nose, and its major purpose is to house the bony labyrinth to support the mucous membranes to trap contaminants when you breathe in. The parietal bones are flat bones, and there's really not any uh, landmarks. I mean, they are pointed a little bit in the upper outer corners, so you might notice that you have posterior corners to your head at the top. Those are the parietal eminences, and it's basically just that, and then the four surrounding sutures, and that's all there is to the parietal bone. It's basically the whole thing is squamous, and it comes to at the outer upper corners. It comes to a little um, prominence right there. A little the angle of curvature is a little bit sharper there than the rest of the parietal bone. So that's about it. No bony landmarks. Not a whole lot to memorize here. Just the suture borders on each side. The opposite side parietal bone forms the sagittal suture up front. The coronal suture on the lateral aspect of the head. The squamosal suture, and then with the occipital bone, the lambdoidal suture. So. All right, sphenoid bone. It says it's a lateral aspect. This is kind of lateral posterior. I think it's about 15 degrees posterior to anterior, so it's kind of lateral oblique here. But we got lots of parts. Okay, so this isn't going to be the only view you're going to see. You're going to see a top-down view in just a second, and then possibly an anterior view too. Um, but we have the greater and the lesser wings. Those are the major parts of the cranial floor. Now, at the mid-sagittal plane, we have what's called the sella and surrounding structures of the sella turcica. So the sella turcica literally translates to Turkish saddle. So I invite you right now to go look up a Turkish saddle on the internet, and you'll see that it's scoop-like. It has the conventional saddle, but it's got a backrest and a front, almost like a front rest too. So it's shaped like almost like a double parabola, like you would see in math. You would see one parabola, like conventionally, from the back of the backrest to the front, I guess, and then invert that parabola and turn it 90 degrees, and you have the saddle portion. So it's a really unique shape, and whoever named this first clearly had seen a Turkish saddle before. That's why they named it Sella Turcica. So the dorsum sella is the backrest to the Turkish saddle, and it comes to two bony points at the top. Those are called the posterior clinoid process. And then the lesser wing kind of forms the anterior scoop to the Turkish saddle, and that's where they come to. That's kind of like a manta ray shape, and it comes to an anterior clinoid process. The pterygoid hamulus actually is the bony support and tethering points for the nasal pharynx. Okay. So the pterygoid hamulus is just anterior and superior to, at the midline, to the cervical spine. And it's anterior, the pterygoid hamulus is anterior to the petrous ridges on the lateral perspective. So it kind of overlaps with, you don't see them on a lateral skull or a lateral C-spine because they overlap with the mandibular rami, but they are there, and it's, I believe, the tethering points for the soft tissue of the pharynx, the oropharynx. Okay. The greater wing articulates and forms a suture with the temporal bone, and then the anterior portion of the greater and lesser wing forms the back of the orbit. So you see the crosshatch, see where it labels the greater wing? Now go to the right hand side of the slide. You see that part that's unlabeled and kind of crosshatched? That's the portion that forms the posterior of the orbit. And then you can see the superior orbital fissure and the optic canal and foramen tucked underneath the lesser wing. That's where the optic nerve travels through the sphenoid bone to get to the back of the orbit. Okay, the clivus is the vertical portion just below. It's a vertical oriented face of bone just below the dorsum celli, and the clivus leads to is in between the dorsum celli and the foramen magnum of the occipital bone. And then there's a lateral pterygoid lamina. I believe the lateral pterygoid lamina connects to the temporal bone and the petrous portion of the temporal bone. All right, so here is a top-down view. They say in the book that the superior aspect of the sphenoid bone kind of resembles a bat shape. But we can see by the expert opinion on this slide that maybe that's a stretch. So, hope you like my geek humor. So this is the same slide, but if we were looking at the bone from like we had cut open the skull from the top and removed the brain, and we're looking down at the cranial floor. This is the structure. This is how it would appear, the sphenoid would appear to us. So the lesser wing, again, manta ray shaped, and then the horns are the anterior clinoid process, and then there's a divot in between the lesser wing and the dorsum sella. That is the seat of the Turkish saddle. That's the sella turcica. And then the little prominence above that is the foramen rotunda. Underneath each anterior clinoid process, the tuberculum sella is the bony prominence in front of the sella turcica, which forms like the anterior, it would be where the saddle horn would be on a conventional saddle. The foramen rotunda is a foramen. It's not the optic canal, but it's close to the optic canal. It appears laterally to the sella turcica on each side. And then the foramen ovale and the foramen spinosa appear out close to the border of the temporal bone and the petrous portion of the temporal bone. The dorsum sella is the backrest to the Turkish saddle, and it has two corners to like the back of the chair. The corners to the back of the chair are the posterior clinoid processes. And of course the optic canal, and then the optic foramen, which you cannot see, it's underneath the lesser wing. That leads to the back of the eye socket. All right, at the very back of the skull, the occipital bone forms not only the posterior inferior, like the bottom third of the posterior of your head, but all of the base of the skull. So all the way forward to junction with the spine. The occipital condyles those are the facets that junction, or yeah, not facets because they're condyles. Duh. Those are the articular surfaces, rather, the condyles that articulate with the lateral masses of C1. Okay, and it is the occipital bone, condyles, and the lateral masses of C1. In order to turn your head side to side, the lateral masses of C1 are gliding back and forth on those occipital condyles. And that gives you your ability to shake your head no. Okay. The foramen magnum is where the spinal cord passes through, specifically the medulla oblongata passes through the foramen magnum. The external occipital protuberance is a palpable landmark in the middle of the occipital bone. Just go to the back of your head, and then it's kind of rounded, and then all of a sudden it cuts in a little bit as you know, as your neck starts to form. All right in that region, you're going to feel a bump on the middle in the mid-sagittal plane, right as your skull joins your neck. That is the external occipital protuberance. And then the squamous portion, again, that's the flat bone portion. Even though it's rounded, it's classified as a flat bone, so that means it's got the diploid structure. The squama, again, just means flat portion without any noticeable landmark. It's just a smooth sheet of flat bone. And then the basilar portion junctions with the clivus of the sphenoid bone that we mentioned earlier. The squama, superiorly for the occipital bone, junctions with the parietal bones. Laterally, junctions with the temporal bones. So here's a side view of our occipital bone. There's the squama, there's the external occipital protuberance, or the inion, as we call it. It is a palpable landmark. The condyles articulate with the atlas, and then the basilar portion anterior to the foramen magnum does junction with the clivus of the sphenoid bone. And we'll see that when we go back to the cranial floor diagram. The temporal bone. From the side view, it's got a squamous portion, it's got a petrous portion, which is kind of posterior. It's more what I would call medial versus lateral, not really anterior posterior. Yes, the mastoid process I would consider part of the petrous portion, but the squamous portion is typically the lateral, or the lateral aspect of the skull, versus the petrous portion. Typically you're talking about penetration into the skull and surrounding the middle and inner ear. The landmark you're already familiar with on the temporal bone is the external acoustic meatus, And I've got a break here so that I can have a meeting. So I'm going to pause it right here. I'll get back to this after my meeting. All right, guys, I'm back. Apparently I was mistaken. It's 10:30. The meeting is not 10 o'clock. So you guys are familiar with the EAM. You might be familiar with the zygomatic arch. Mandibular fossa is the location of the TMJ joint, temporal mandibular joint. There's a styloid process, tympanic portion. The tympanic portion refers to the eardrum. The mastoid process, or the mastoid tip, we already touched on when we position for the AP open mouth cervical spine. Zygomatic process forms the posterior half of the zygomatic arch, and of course it junctions with the zygoma, the facial bone, to form the zygomatic arch. So the condyle of the mandible articulates with the mandibular fossa, but the coronoid process of the mandible actually slips underneath the zygomatic process of the temporal bone and tucks under it when the jaw is closed. So this is our side view. Squamous portion will junction with the parietal bones superiorly, the occipital bone posteriorly, and the sphenoid bone anteriorly, I believe. The sphenoid bone forms a portion of the lateral aspect of the skull, the greater wing does. All right, so if we were to look through a patient's head, I don't know, maybe with an x-ray machine, this is what we would see. And remember how I said the petrous ridge, or the petrous portion of the temporal bone, was the most bony, dense region in the human body. That is, it's compact bone and it's pretty thick. And that's to soundproof the middle and inner ear so that you don't always hear the blood rushing through your head. Now, sometimes, especially when you have fluid on the ear coupled with sinus congestion, you actually override that soundproofing and you can actually hear yourself breathe, and you can hear the blood rushing through your head. So that soundproofing is not foolproof, but for the most part, wouldn't that drive you batty if you kept hearing this whoosh, whoosh, whoosh when you were trying to think, and then you realized that was the sound of the blood going from the carotid arteries going up into your own head, and you were actually hearing the whoosh whoosh sound as it passed by your middle and inner ear. That would drive you nuts. It would drive you bonkers. So kind of by design, that soundproofing prevents you from hearing your own internally generated sounds. Now, it's not 100%. You will hear occasionally your heartbeat in certain conditions, or your breath sounds in certain conditions. And if you jam your fingers in your ears, you notice your voice. You only hear your bass tones, or your voice appears to get deeper. It doesn't really get deeper. It's just the only sound that you're hearing from your voice is what's the sound that's moving through your skull and your soft tissue and penetrating through the petrous portion and getting directly to the eardrum around the EAM. So don't stick your fingers in your ear. Don't stick anything in your ear except for your elbow. And you might soon figure out that it's impossible for you to stick your elbow into your ear. So the petrous portion, the petrous ridge, the petrous portion is kind of on a radiograph. It's going to look like a white triangle pointing toward the center of the head. Okay, the very top, the most superior aspect of the petrous portion is the petrous ridge, and all the petrous portion is what we're trying to get out of the way in AP and PA axial projections of the skull, so that we can see other pieces of the skull. So we tip the skull forward or backward a little bit, or we throw a tube angle on in order to get the petrous portion the heck out of the way of what we're trying to see. You can see in a straight AP, it looks like it gets in the way of evaluation of the orbit. It's right at the same level as the lower orbit. And in fact, that's a mark of a quality PA, straight PA projection of the skull, is that the petrous portions fill the orbit space, completely superimposing and filling the orbit shadow on a skull. Okay. They have chopped away the zygomatic arch, or a little bit of it. You can kind of see the outline, the dotted outline of the zygoma, where the zygomatic arch fills. We will be doing radiography of the zygomatic arch at the tail end of the chapter, and I'll show you how to do those projections. It's going to be an inferior superior tangential projection of the zygomatic arch. All right, so the petromastoid portion combines the petrous and the mastoid portions, forms the inferior posterior part of the temporal bone, articulates with the parietal bone. At the superior border, occipital bone at the posterior border. Usually the mastoid portion contains air cells, which vary greatly in size, number, and pneumatization. And the function of the mastoid air cells is a ballast tank for the middle ear. As you may know, the ear has three. It's got the outer ear, which you're most familiar with, and then there's the eardrum, the tympanic membrane, and then that begins the middle ear, and then eventually the inner ear. Well, the middle ear has to maintain uniform pressure with the outside air, or else you blow out your eardrum, or you cave in your eardrum and the eardrum tears. So there's two ways to regulate the pressure of the middle ear. One is a ballast tank, which is an effective storage of additional air in the mastoid air cells. And that's in the mastoid process. And the other one is the eustachian tube. The eustachian tube is a duct, mucous membrane lined, that connects the oronasal pharynx with the middle ear. And so when you chew gum on an airplane flight, you might notice that your ears pop or they change pressure. That is your eustachian tube balancing the pressure relative to the cabin pressure as you change altitude. Okay, so that eustachian tube plays a vital role as a person changes from a higher air pressure to a lower air pressure, or a lower air pressure to a higher air pressure. Just the act of chewing and swallowing will cause an air bolus to leave the oral pharynx and travel up the eustachian tube and deposit more air into the middle ear, or will cause the middle ear to decompress and push air down the eustachian tube into the throat where it can exit. So that system effectively works to keep the middle ear the same air pressure as the outside of the eardrum, or otherwise your eardrums start to feel funny and your head feels kind of, well, it's pressurized. I think the worst of the two is when the middle ear has more pressure than the external ear, and the eardrum is bowing outward. That really feels uncomfortable. So can be mitigated by chewing gum and swallowing. So, and then if you don't have any chewing gum, just hold your nose closed, hold your mouth closed, and swallow, and tuck your chin and swallow, and it should trigger the same mechanism. So, skull sutures and junctions. We already covered the sutures: the sagittal, coronal, lambdoidal, and squamosal. Those are the sutures. The sagittal suture is on the sagittal plane between the parietal bones. The coronal suture is between the parietal bones and the frontal bone. The lambdoidal suture is between the occipital bones, the temporal bones, and the parietal bones. And the squamosal suture is largely between the parietal bones and the temporal bones, but also the sphenoid bone and the temporal bone. The lambda is the posterior junction between the sagittal and lambdoidal sutures. I'll say that again. The lambda is the posterior junction between the sagittal and lambdoidal sutures. The bregma is the superior junction between the coronal and the sagittal sutures. The bregma is the superior junction between the coronal and the sagittal sutures. The Tyrian, and that P is silent, so it's the Tyrian suture, is the junction of the coronal suture with the squamosal suture. And that is roughly above the ear. And then that's the more anterior of the lateral sutures. The asterion is the more posterior of the lateral sutures, and it's the junction of the squamosal and the lambdoidal suture, which is just behind, it's just posterior to and superior to the mastoid tip. Okay. You can't really palpate the junctions of the sutures. Maybe the bregma is palpable, but the rest of them, you don't really notice them. If you have a anatomy, if you got a skull model, you'll see them, but you won't really palpate them on a patient. You just kind of have to figure out where they are. Okay. Now, a handy method to eliminate confusion between the two lateral sutures, the Tyrian and the asterion. Remember that the asterion is the posterior of the two lateral sutures. You see what I did there? The as is posterior. Okay, so that's a handy way to keep the Tyrian straight from the asterion. Is the as is posterior. All right, skull topography. Be able to locate the following landmarks. Now we will run through these in lab demonstration. Glabella, inner canthus, outer canthus, nasion, infraorbital margin, acanthion, gonian, inion, mental point, EAM, top of ear attachment. Some of these you've already heard of, like I already mentioned the nasion and the glabella in this chapter. I already mentioned the outer canthus. You're already familiar with the EAM. The top of ear attachment is pretty easy to figure out. And I think I have mentioned when we did the Fuchs method, I mentioned the mental point and the gonian, which is the angle of the jaw. So let's go through these again just to be thorough. The glabella is the prominence of bone between your eyebrows, or where your eyebrows would be if you haven't shaved them off and painted them back on. Okay, which I don't understand, but okay. Yeah, sure. Sometimes it's done right and it's pretty. Other times, oh, what did you do? But anyway, I digress. The glabella is the bony high ground between where the eyebrows should be. Okay. The inner canthus is the inner corner of the eye. It's where your tear ducts are. The little red, puffy thing. You see it. Yeah, that is called the, is it the laminary duct? I think so. It's called lacrimal duct. The tear duct is located at the inner canthus. The outer canthus is the outer corner of the eye. Okay, those are soft tissue landmarks, not bony landmarks. Okay, the orbital rim itself is different than the inner canthus and the outer canthus. The inner canthus is a soft tissue. It's the location of the tear duct, and the outer canthus is the outer corner of the eye, not the outer corner of the orbital rim. The actual where the upper eyelid and lower eyelid meet on the lateral aspect of the eye. That's what I'm talking about. The nasion is the divot at the top of the nose, just inferior to the glabella. Okay. You could say that the nasion is the beginning of the bridge of the nose. The infraorbital, your glasses, if they fit well, sit and rest on your nasion. The infraorbital margin is the lower margin of the orbit. Infra means below. So pertaining to the below the orbit, the margin below the orbit, it is that you can actually palpate it. On older folks, you can see it across the room because they're so overworked and tired that they have bags under their eyes, and you can actually see the skin has regressed, and you can actually see their orbits, their infraorbital margins from across the room. So young folks have nice, strong cheekbones and don't have sagging collagen yet, so they don't have, you have to actually push to find their infraorbital margins. Acanthians, the acanthion is the bony spine of the maxillary bone at the mid-sagittal plane. It is at the base of the nose. Now, where's the base of your nose? Well, you know where the two nose holes are, your nostrils, right? You know how there's that little skin in between them, the septum, the soft tissue septum. Well, if you push up and back on that soft tissue septum, you might feel something like a little pointy spear. That's the acanthion. Now, don't do that really hard. That's going to hurt. It's going to make your eyes water. Pushing on the acanthion is, that's another pressure point, but this one stimulates your tear ducts and also can trigger a histamine reaction, so can lead to instant, if it's pressed way too hard, it can lead to eye watering, and your sinuses instantly become inflamed and engorged with excess mucus. So that's the acanthion, and it's got some nerve endings there that are really, really sensitive. So just gently push up on your nasal septum. Don't let your finger slip, because then you'll get accused of picking your nose. But push up on your nasal septum and then just slightly back, and you should feel a little bit of bone there. That's the acanthion. Okay, it really is the junction of, soft tissue wise, it's the junction of the nasal septum and the upper lip. And yeah, if you push down on that, you can also feel that without pushing your nose up. So the gonion is the angle of the mandible. So it's the corner of your jaw, kind of underneath your ear, but a little bit anterior to that. Okay, that's the gonion. The inion is also the external occipital protuberance. That's that. Remember the back of your head when we covered the occipital bone just a couple slides ago? It's the bump right where your head, the back of your head, meets your neck at the mid-sagittal plane. And now it's time for the meeting. Let me finish this slide up. The mental point is the tip of the chin, the EAM, you already know, and the top of the ear attachment, you can figure out. It is where the ear tethers to the skull, okay, soft tissue wise. All right, so I'm going to pick it up on the next slide, guys. All right, guys, back from my meeting. I think we're just adjourned for lunch. Hopefully I can get this wrapped up. All right, so these are what you would call not necessarily palpable landmarks, but the topographic landmarks on the anterior skull. I've already explained to you where the glabella was. The nasion is the divot. So the glabella is the high ground, the bony high ground between the eyebrows. Just inferior to that is the nasion, and then at the base of the nose, at the base of the nasal septum, where the nasal septum soft tissue attaches to the upper lip, and that's the location of the acanthion. The infraorbital margin is the lower margin, lower border of the orbit. Outer canthus of the eye is where the eyelids meet laterally. Inner canthus of the eye would be where the eyelids meet medially. It's the location of the lacrimal or tear duct. Okay, the mental point is the tip of the chin, and then the angle of the jaw just below the earlobe and just anterior to the earlobe is the gonion. Okay? And then from the lateral perspective of the head, the external acoustic meatus or auditory meatus, the hole in your ear, connects with those various anterior landmarks to form several topographic lines. Okay, so the most superior of which is the glabellomeatal line. Then you have the orbital meatal line, which is the outer canthus to the EAM. The infraorbital meatal line, which is the lower orbital rim to the EAM. The acanthomeatal line and the mental point. Notice for the mesocephalic skull, there's a 7-degree difference between the OML and the IOML. Okay. So mental meatal line, and then there's the glabelloacanthial line that marks, that one is usually vertical when the patient is in a neutral posture as far as tipping the head forward, tipping the head back. The glabelloacanthial line becomes a vertical line when the posture is neutral. That is, the patient hasn't flexed their head forward, their neck forward, or extended their neck. Neutral posture, vertical glabelloacanthial line. All right, anatomy of the facial bones. There's going to be 14 of these. We can see some of them here: zygoma, mandible, maxillary bones, nasal bones, lacrimal bones, ethmoid bones. So the ethmoid is both, and then there's the vomer. The ethmoid is both part of the cranial bones and the facial bones. Okay. The lacrimal bones are the tiniest ones, and they also make up part of the orbit. You're going to have to know the bones of the orbit as well. The zygoma is the cheekbone. The maxillary bone is the bone of your upper lip. The mandible, of course, is the jawbone. And these all have various parts. So let's get into the individuals. Now we can see the lacrimal bone just a little bit better from the lateral perspective. There's the zygoma connecting, making the zygomatic arch. And we can see that the coronoid process of the mandible tucks under the zygoma and the zygomatic arch. The anterior nasal spine, acanthion, displays well on the profile of the maxillary bone. And on the profile view of the mandible, you can see the gonion and the TMJ joint. All right, our maxillary bones is the largest immovable bone of the face. Okay, the largest movable one would be the mandible. Okay, each articulates with all the other facial bones except for the mandible. The maxillary bone doesn't actually articulate with the mandible. The mandible articulates with the temporal bone. The maxillary bones also articulate with the frontal and ethmoid cranial bones. It forms part of the lateral walls and most of the floor of the nasal cavity, and it forms the medial part of the floor of the orbit. Maxillary bones have an alveolar process, just like the mandible does. The alveolar process is the spongy bone that supports the roots of the teeth. So the alveolar surface, or the alveolar processes of the maxillary bones, that's where the teeth are, the upper teeth are coming out of the bone, is the alveolar process. Okay. The anterior nasal spine, that's the acanthion. It's a forward-pointed process at the midline junction, and it is right behind the soft tissue nasal septum. Okay. Zygomatic bones, those are the prominence of the cheeks. Okay. They are at the outer, that is the lateral inferior corner of your orbit. Okay. So the zygomatic bone forms part of the lateral border of the orbit, but also part of the floor of the orbit. Right? The temporal process extends posteriorly to form zygomatic process of the temporal bone. So the zygomatic arch is actually the temporal process of the zygomatic bone plus the zygomatic process of the temporal bone, if that's not confusing enough. Okay. Palatine bones. Palatine bones weren't on the diagram. What the heck, Mr. Tillotson? They are two L-shaped bones composed of vertical and horizontal plates. The horizontal plates articulate with the maxilla to complete the posterior fourth of the bony palate. The vertical portions extend upward between the maxilla and the tergroid process of the sphenoid in the posterior nasal cavity. So the reason you can't see them is they're kind of in between the maxillary bones and the sphenoid bone, embedded inside the soft tissue of the roof of your mouth. It's kind of hard to get a decent angle to demonstrate where the palatine bones are. They're L-shaped, and that's where they're, how this describes, that's where they are. I've never actually seen them on an x-ray. Okay. It's a little bit of trivia that you have to know to pass the registry exam, much like the rest of this chapter. The vomer is a thin plate of bone situated in the mid-sagittal plane that makes the floor of the nasal cavity, so slightly superior to the palatine bones and anterior to. Forms the inferior nasal septum, so it does articulate with and forms a suture with the ethmoid bone and the perpendicular plate of the ethmoid bone posteriorly. The superior border articulates with the body of the sphenoid bone. Superior part of the anterior bone articulates with the perpendicular plate. Posterior border is free. It just kind of floats. Yeah, so it's real tricky to work out where that is, but basically it's at the bottom of the nasal cavity, in between the maxillary bones, inside, like underneath the, I guess there was the superior concha and then the medial concha or middle concha. Yeah, underneath the middle concha is the vomer. All right, that's it. Got lacrimal bones, you've got two maxillary bones, you've got two zygoma, you have one, is it two mandible bones or one mandible bone? I'll have to look that up. Palatine bones, and that's it. That's the facial bones. So I have walked through the anatomy for both the cranium and for the facial bones. Two separate categories, 8 bones in the cranium, 14 bones in the facial bones. We've talked about topography, that is the the landmarks, the glabella, the nasion, the acanthion, the outer canthus, the inner canthus, the inferior orbital margin, the EAM, the gonion, the inion, and the mental point. We've talked about the lines between some of those landmarks, like the glabella meatal line, the orbital meatal line, the infraorbital meatal line. We've talked about the various shapes of heads, the morphology, and there are three basic shapes. There's the most typical shape, which is the mesocephalic, which features a 47-degree angle between the petrous ridges and the mid-sagittal plane. Then there is the bradycephalic, which is wider than it is tall. It has a 54-degree angle between the petrous ridge and the mid-sagittal plane. And then the dolichocephalic skull is narrower side to side than it is tall. It's a very tall skull. And that only features a 40-degree angle between the petrous pyramids and the mid-sagittal plane. And the reason those angles are important is because the positioning that I'm going to teach you in the next lecture is based off the mesocephalic skull. And so the degree of tilt of the head forward and backward and or the tube angle that you apply may vary with alternate skull types. Because of the difference, because I said when we covered the petrous pyramids and the petrous portion of the temporal bone, I said the whole point of skull radiography in the various positions and putting angles on the AP and the PA projections is to get these things the heck out of the way of what you're trying to see. And so if they change their orientation to the mid-sagittal plane in degree of angle based on skull type, then you may need more angle or less angle depending upon what skull type you're doing from the standard being the mesocephalic skull type. So for example, next week I'm going to talk to you about the Caldwell projection. It is a PA projection of the skull. Central ray exits the nasion, featuring a 15-degree down angle. Okay, so you should know how to do it. All you need to know is how do you tip the head? Well, you tip the head, I believe, so that the orbital meatal line is horizontal, mid-sagittal plane perpendicular to the image receptor. Angle the tube 15 degrees down, centered to the center of the image receptor, and then bring the level of the image receptor to the patient's nasion, and achieve detent, and boom, you have a Caldwell projection. Now, all those directions are based on mesocephalic morphology. If you x-ray a dolichocephalic skull, the whole point of the 15-degree down angle is to get the petrous pyramids, or the petrous portions of the temporal bone, below the orbits. But if you have an alternate skull type, 15 degrees might not be enough angle, or it might be too much angle. See what I'm saying? So that's why we had to learn the morphology. All right, and don't worry if you didn't understand what I was talking about with the Caldwell projection. It's going to be in next week's lecture, or the next lecture I record whenever we cover that. All right. Review the anatomy pertinent to the facial bones and the skulls. Exams. Okay. So everything we covered here, fair game for a quiz. All the stuff in this lecture. In fact, your first quiz is anatomy and topography. So it's about, I'm going to ask you about the lines. I'm going to ask you about the landmarks. I'm going to ask you about the parts of the bones. It's a lot. So see why I subdivided it all out to itself? Well, anyway, this has been an hour and a half for just roughly 40 slides. So I've talked your ear off already. Keep them books open and crack those workbook exercises. Y'all are going to need it on this chapter. See you next time.